All right. Welcome everyone to another episode of Profound Conversations. Today, we're going to be talking about higher education, and we're actually going to delve in a little bit into some professional schools because our two guests here with us today are in professional schools of medicine. And so this has been a really challenging time for higher ed. I know we've been hearing a lot about primary school and the challenges of schools reopening, not reopening, the teachers being uncomfortable going back to school. But we haven't had a whole lot of conversations around higher education. And institutes of higher ed have been really experiencing challenges as well with breakouts, remote learning. You have professors, a lot of professors who are tenured and older, who have not operated in a virtual environment before. So this is a whole new learning experience for them to have to operate classes virtually. And I think when we start talking about some of the professional schools, it's really the clinical, they have some unique challenges of a lot of that work requires being in contact with other human beings. The whole practical side. We have issues around recruitment or students coming back to school. Should students be paying their full tuition if they're not getting the full experience? So there are a host of issues impacting higher ed. And today I'm going to ask our guests to jump right in and start talking with us about some of the challenges that they've been experiencing in this new world of COVID-19 as it impacts higher education. So Dr. Lambert.
Thank you, Linda, for that introduction. I myself serve as an assistant dean at a very large academic medical center, particularly in the graduate school of that medical center. So we have a lot of master's students who are pursuing things such as, becoming a physician assistant or healthcare policy and research or public, population health sciences, which is similar to public health. But we have a lot of PhD students as well who are studying things like cancer research and neuroscience. And, I think you're right in the sense that, sometimes we think about the impact on, classes and, just the engagement or the transfer of knowledge and that sort of shift in paradigm from moving from physical engagement to now a sort of virtual world. But, even for a lot of those students, they have this component where they're working in the laboratory. They need to sort of physically be on campus and in physical environments. And so it's impacted those students in many ways. And then, as you would expect at a large academic medical center, with that collaborates with the hospital, we have medical students. And, many of those medical students, including those who've finished their MD and gone off to residency or fellowships, they're still in their training part of their careers. They have been impacted in very significant ways as well. I think it's just been a reimagining of our sort of the total way that we have thought traditionally about training students. So I'm happy to touch on some of those ways, but I'll give Dr. Thornton a time to respond as well.
Thank you so much for the question, Linda. I'm really excited to be in this conversation with you and with Dr. Lambert, and grateful to the whole team for inviting me today. So I wear a variety of different hats within my organization, but one of the things that I am responsible for is the very first course of the first year of medical school, which is a topics in interdisciplinary medicine course focused on disparities and inequities in health and healthcare. And truthfully, I think that it's medical school in many places starts in the summer. So a lot of people started in mid-August, late August. And then other phases of medical training, like the residency programs, have their transitions in the July timeframe as well. So you can imagine in pretty short order after the initial declarations around state of emergency in the springtime, February, March, April, there was a lot of change happening, a lot of reimagining, like Dr. Lambert said, of how we were going to do things. In the context of ongoing uncertainty, frankly, about what would be recommended at any given time in any given place. And so at a certain point, I think we made the decision with the first course of medical school for the first years, because it is a non-clinical course, to move forward with an abundance of caution. These are students who were coming to our institution from all over the world, frankly, and all over the country, and would have been traveling, which can potentially be a high risk time for exposure. And when we think about what the ramifications are of social distancing and what kind of space layout would be required, we were considering ways to have students come in for some small group activities and smaller groups. And I don't know if you'll remember back to this, but there was a point in the summer, I want to say, I don't remember all the specific details, but I want to say maybe late June, early July, where there were questions about whether visas were going to be allowed for students coming internationally to do remote programs only. And so that precipitated a series of planning scenarios where we were going to potentially be in a position where we sort of had to make the decision to do some, I think it was 20% of the instruction in person in order to be in adherence with that. And, I think thankfully there was a reversal at the federal level of that mandate, which I think in the context of like us all actively trying to reimagine how we were going to do things we had traditionally done in person, we're then going to have to reimagine them again to do 20% of that, in person, and potentially other parts that we were planning, previously to be 100% virtual. And I think so that's been an evolving picture. I do agree with Dr. Lambert. I'm PhD trained, but also a practicing physician, and speaking to the medical school side of things, I think at Hopkins, there's been a concerted effort for courses like anatomy, for the clinical skills development courses, where you really cannot replicate the experience virtually, to identify safe ways to bring students together for those experiences. And being somewhat removed from those elements of the curriculum discussions, I don't have a lot of visibility into the details, but I can say that I know firsthand, just from students' testimonials, that having the opportunity to do that in some of those elements in person safely is really meaningful for their growth and development, their learning. And also, we're really trying to build a community of learners. And, there are significant challenges to that when people are restricted to kind of a Zoom platform, so to speak, as their primary way to connect. So I know some students who are, sharing apartments together and creating other opportunities to kind of have more interaction with people who are basically now part of their household. And a lot of effort going into kind of planning some virtual social spaces for the students to build connections, but lots of challenges.
Now, when you're doing that in terms of having students be together and connecting, you do have the possibility of there being some transmission of COVID. And you've had some universities that have become real hotspots. So what is the plan now that, students are coming back into these hybrid environments, some in person, some virtual? What happens if there's an issue? Is there a plan in place?
What I can say is, basically from my vantage point as a member of the faculty at my own institution, which is that institution-wide, the mask requirements are in place, and faculty on the university side have been given general information about how to address any resistance to adherence to those mask requirements. My general sense of the students is that there's particularly in the medical sciences, which, many of these students are in a position as they transition into their clinical years where they're essentially functioning as an apprentice physician, are in clinical environments. We expect them to keep the safety of the patient as paramount, and they're similarly in those instances required to wear a mask and are given access to the same kind of protective equipment that we expect the faculty in those environments or the other clinicians in those environments to have access to. I know that at different phases in the pandemic, there were decisions made about protecting students from direct patient care with known COVID positive patients just because of the concerns about PPE. And briefly, in a lot of medical schools around the country, there was, rotations were suspended for a period of time in order to be able to do kind of a full safety assessment to do what was necessary to ensure we had physical spaces allocated safely for distance. We usually are working in very close quarters, in the hospitals and in the clinics. There's commonly a pretty crammed, shared space where the student doctors and the preceptors, as we call them, are all together, sitting shoulder to shoulder almost. And so we had to do a lot of reimagining of how we were going to use clinic rooms, how we would involve them in some of the virtual care we're now doing. And I think there's been a lot of challenges in all of that. But I can speak, at least at my institution, my sense is that there is a clear understanding of the importance of following the masking and social distancing guidelines that are in place. There's a lot of signage posted. There's conference rooms that have been repurposed into places where people can safely take breaks and eat lunch and, be distanced from one another. And we're really thinking about how the students can continue to learn so that they can stay on track in their trajectory to, transition into residency programs and the like, but do it in a safe way. So I'm sure Dr. Lambert has other things to add to that. There's also the issue of how do you have students engage in their laboratory spaces effectively and safely. And I know that, the bench scientists in our space have been doing a lot of work to reimagine that, to create protocols for knowing who's where at what time and the like.
I want to shift a little bit and ask the question around impact this has had on different communities. Are we experiencing, or are you experiencing, that the COVID-19 as it relates to the continuing education of students of color, have they been impacted, or has this impacted communities that your institutions may serve?
Yeah, happen to serve as a dean of diversity, assistant dean for diversity and student life, and this is one of the things that I've been paying very close attention to. Dr. Thornton, mentioned the impact, particularly on international students and our international scholars with the visas, and I think for a lot of international students, just the simple fact of travel restrictions has been quite impactful on their educational pursuits. And just speaking for our institution, for example, our graduate school is comprised of 30 to 40% students who are international student and on visas. So it has a significant impact on the students and the institution. But also thinking about students who are from the United States who happen to identify from underrepresented groups in medicine or underrepresented groups in science. So this includes racial ethnic minorities, individuals who come from socioeconomic disadvantaged backgrounds, as well as individuals who have, disabilities and who often are faced with challenges in, sort of their educational pursuits because of that. I think that this pandemic has had a very significant impact on those communities. One of the things that we do at our institution that is probably very, very common across the nation, we host summer research opportunity programs for students who are interested in applying to our programs. So, for example, if you're interested in going to medical school, we have a sort of pre-med summer program where we usually, under normal circumstances, bring you to the college, and you get to see what life is like as a medical student. You spend 7 weeks and you do research, and you get a chance to interact with the physicians and the medical students, and it's just a phenomenal, life-changing experience for those students. We have very similar programs, one that I direct for those who are interested in graduate school and the PhD route and becoming a research scientist. We put them in a laboratory for 10 weeks, and they interact with graduate students, our postdoctoral fellows. They get to do research. They often, at the end of it, will do presentations. But it's all really sort of, predicated on the fact that they're here on campus interacting. So the pandemic put a huge wrench into that. And we had to be really creative as to far as, what we were going to do. A lot of programs across the country were just simply canceling, saying, hey, we can't host students if our laboratories are closed down. One of the tough decisions that we made, we decided to host a virtual program. So this really involved thinking about the sort of opportunities that we provide those students. So we have a number of programs that target high school students and college students, but I'll just take the college student program, for example. This program typically will take college students, allow them to do research at an academic medical center. What we did instead, we taught them how to do grant writing. So there's the National Science Foundation has these fellowships for graduate students that will fund, your training. And we basically taught them how to write that grant. So they actually wrote one of those grants so that they could potentially submit for graduate school. And that's something that we wouldn't ordinarily do. It involves really, a lot of just creative thinking about the type of research that you would propose, and matching with graduate students and labs. But we also supplemented that with other things, where we critically read scientific papers and analyzed what was going on, even sometimes with COVID. We had virtual community building activities where, we would, come on Zoom and have like a Zoom game night. And, because here, this program takes students from all across the country, even as far as California or Puerto Rico, and students who don't know each other. We bring them into, this sort of virtual environment and try to help them get to know each other. That's challenging. That is challenging. But that, I think, is one of the key things of why students from underrepresented backgrounds are so successful, especially with us, is because we have that sort of cohort where we help build these communities, and we have people that you can lean on for advice, and so that you're not the only one going through these challenges. And it remarkably is very successful because of that. But so those sort of programs we had to sort of reimagine. But just the simple fact that a lot of those students are not getting the sort of research experience or the sort of clinical exposure that they would ordinarily get, that would make them competitive for graduate programs or medical programs. That, I think, is a huge piece and a huge challenge. And I think it's impacted those underrepresented groups a little bit more. For a lot of students who sort of have the privilege to either know early on, maybe like, let's say in high school, that they should be doing research, they'll find out research programs in high school, or their parents will connect them with, another parent who's a faculty member and say, hey, can you take my son or my daughter or my nephew or my friend's son in your laboratory? They'll get that research experience in high school. A lot of students who come from sort of disadvantaged backgrounds, they don't have that sort of privilege. So I think, we're almost faced with this sort of challenge of, how do we now level the playing field, and how do we ensure that we are still moving the needle on diversity when not everybody has the same access.
Now, so do you think this is going to create a pipeline issue? in terms of, some of these underrepresented groups when you look 2 or 3 years down the line in terms of that whole admission and recruitment process in terms of getting them into these programs?
Yes, it very well could, and I think that's something that we're just going to have to watch and see, what happens, because some things are it's on the student side to gain the experience and to do the work and get the grades that's necessary, but the institutions also have to realize the times that we're in as well, and they play a particular role in the type of students that they want to accept. So it's on both sides, and I think we have to see how this plays out.
And just maybe to piggyback on that a bit as well. First of all, at least in medical education, and I would hazard to say this is not unique. There are long-standing issues around the socioeconomic diversity of students who are matriculated to medical school, as well as their racial ethnic diversity, that have been persistent problems. I think many of those are potentially byproducts of other structures in terms of the way that what gets prioritized in the selection processes in many institutions. I will say that the potentially another thing that the pandemic has pushed is that many institutions have gone from a hierarchical grading system to a bit of a flatter grading system for rotations. And even in things like college admissions, there have been shifts away from SAT scores, given all of the structural challenges and even accessing a site where you can take the test. And I can say that definitely for those students who are, so there's a couple ramifications, I think, in medical education and in postgraduate training of physicians. One is that there are students, particularly those students who are from lower economic backgrounds, who already are not the norm, unfortunately, in terms of the population of people training to be physicians, and who potentially are more likely to be otherwise from underrepresented or marginalized groups, have had to go back and support family, right? Like they've had to go back and take on a job or something else to support a family that is economically more at risk from the financial ramifications of the pandemic. And then if you think about those safety net training programs in places that are otherwise underserved by, or sort of in terms of having access to a robust healthcare workforce, many of those programs rely on international medical graduates who've gone through the sort of extraordinary extra step of getting passing all of their boards in the United States. And I know, just having been, involved with a few students recently, or a few employees recently, who were going through the process of passing all their boards and applying to residency programs in the United States in the context of the pandemic. There are not only ramifications for the composition of those classes, because people were delayed in being able to get to their destination because of all of the challenges around travel. But also those are people who are potentially working in environments where, for a variety of reasons, there may be higher concentration of infections, or where there may be potentially, resource challenges in those safety net institutions in being able to respond. And I think at different points, just coverage in the media has highlighted the issues around safety net hospitals in, rural environments is one example, or places where there's sort of less resources to make sure all the PPE is in place. Not every hospital is equipped with negative pressure rooms or the ability to convert facilities. And so I think there are a lot of things to consider, in a lot of ways that disadvantage or marginalization, or what we might expect, and or even what people are contributing to patient care in difficult circumstances. may not always take into account some of those issues in terms of the workforce, and the fact that people may also be, disconnected from family that is very far away and facing a variety of challenges in getting here, not just because of the pandemic, but potentially also because of other, federal policies that have sort of negative ramifications on people that are here essentially serving a safety net function in our healthcare system.
Okay, so just so for those listening, tell us what you mean by safety net.
What I mean is, not the Johns Hopkins and the Cornells of the world, but community hospitals in, small communities that don't have a bunch of research dollars coming into them, or, may not have the highest tech intensive care interventions available to them. Maybe a place that has, only a few beds where people can actually get, respiratory assistance like a ventilator. And sometimes in those settings, those are also settings where we struggle to, fully staff up those environments with clinical workforce and physicians in particular. And so there are programs in place, either through kind of loan repayment programs to medical students who are graduating, to incentivize them to go and train in those places, or after training to go to those places and provide clinical care. We know that underrepresented students and international medical grads are more likely to take those safety net roles where they're really providing a service. They may be, one of a few physicians serving a significantly larger patient population than their colleagues in dense urban areas. And that comes with a variety of challenges. And I think, it's important to just remember, that people and sometimes underrepresented students in particular have a particular commitment to giving back to their communities, and may be more likely to take on those really challenging clinical assignments. So it's another way that these kind of dynamics play out around privilege and disadvantage and marginalization in the American healthcare system. And not to mention the patients that they're serving, may also be patients who have limited access to insurance or financial limitations and the like.
And Dr. Lambert, I know you want to jump in. And on this issue around just, who do we have available coming out of the institutions, coming out of the medical schools, coming out of the sciences, that would go back into the community, whether it's their community or, as Dr. Thornton said, whether they're going into that community because it is one of those safety net hospitals or facilities or jobs that they're being incentivized to go into.
Yeah, I very much agree with Dr. Thornton. I think one of the biggest sort of challenges that we face as a nation is really just our health disparities. Just access to healthcare, but also, the sort of, individuals that are providing that healthcare as well can really help in terms of really achieving health equity. I say that to say that, a lot of the encouragement for helping to diversify academic medicine, diversify the medical workforce and even the graduate workforce, really, I think, comes from this notion that a lot of individuals from underrepresented groups have a tendency and a desire to go back into medically underserved areas and work with populations that also are, coming from these same sort of, they look like them. They're getting care from the physicians and the health workforce from individuals who also, look like them. And I think there's been a number of studies to show that does make a difference. So I think, we, certainly on my side, we're charged with really trying to produce as many individuals as we can who are interested in serving in those sort of areas, not just so that we can tackle health disparities and achieve health equity, but really so that we can have a really diversified physician workforce. And we need more. And it's already been projected that we need to increase the number of physicians that we're producing, and we certainly need to increase the diversity of those physicians. And I think there's only good things that are going to happen from that.
One of the issues around some of the health disparities and health equity is, you have issues really where you don't have those that are serving the community actually having that cultural competency to do that, and having more diverse practitioners help solve some of those challenges. You also have a lot of issues in certain communities around trust. And that creates all kinds of issues around compliance with medical recommendations, medication compliances, whether or not people are even going to go to a physician if that physician doesn't look like them, if it's not somewhere where that trust is there. So you're actually pointing out a really big issue that is in healthcare around those health equity issues, that when you don't have diverse physicians, when you don't have people in your community that look like you, it does create trust issues. And I think, if we look at some of the things that we're seeing with COVID-19, these are some of the challenges that we're even having addressing COVID-19. And, I'm spinning off a little bit here, but I think we're going to also have some of these challenges when we do get a vaccine.
Absolutely.
If we have a vaccine and people are not trusting the vaccine, and those that are the scientists behind it, those that are administering those vaccines, if the community has a trust issue, we all have an issue.
No, absolutely, Linda, and I appreciate you bringing up that point. And I want to, even acknowledge that, it's not just, how you look and how you perceive automatically gives you this sort of pass. The trust, it goes a long way, and it takes time to establish. Just because you may be, an underrepresented physician or, a person of color who's a researcher or a scientist doesn't automatically mean that you're going to have the trust of that community. And that's pretty evident. And, I've seen time and time again examples of that. I think, which is why, one of the things that you often find being pushed in research circles is this idea of community-based participatory research, where you actually bring community members at the table as you're designing research projects, engaging them before you sort of, write the grant, or before you sort of say, hey, here's the research that we're doing, and going into the community, you have those members at the table along with you, helping to design and helping to develop the project and the research idea. And not just saying, hey, here we know what's best for you, let us go in and try to experiment and fix things. So, I think even when it comes to the idea of, vaccines for COVID-19, one of the things that I think we need is really people at the table. We certainly need to understand, who's involved in these processes, who are people that we can trust, and hear from those individuals and understand, what's going on with that process, and have those individuals being able to communicate with members of the community who are not necessarily physicians or scientists.
And I guess the only thing I would add is that the trust gap is legitimate in many regards. If you think about people's experiences and what we know to be these sort of persistent structural challenges, and to the way that Black patients in particular, but many patients of color, may be perceived by and construed and evaluated within the healthcare system. This idea that, my challenge in this space as a health equity researcher is making clear that fixing the trust gaps is not about fixing the patient's trust. It's actually about being trustworthy in the care of those patients, and not continuing to, reinforce these misplaced notions about, you know, about differences that are not biologically based and that are not actually factual. The examples abound in history, examples around misperceptions of pain tolerance in African Americans that are wholly based in, kind of racist conceptions of Black people in this country. And I think that's something that the medical profession, needs to do more grappling with, to be sure that we are providing care that is worthy of our patients' trust. And then I think the whole issue of vaccines warrants a show all to itself on what the myriad challenges are around creating enough, around providing good information, around ensuring the safety of products and the like, that sort of exceeds my own expertise. But I do think you raise a really important point, Linda, that all these things are connected, and that it's not only about, a misperception on the part of a patient, but in fact, these may be grounded in, reproduced consistent patterns in people's lived experiences and in the behavior of institutions that needs to be addressed. And hopefully, with people like Dr. Lambert at the table in the educational process of physicians, we are, I hope, positioned to start really holding ourselves accountable for who we train, how we train them, and ensuring that the people responsible for training and educating our future, healthcare workforce, everyone from the folks who are doing population health sciences, who may end up running quality programs and the like, and the folks in finance and, business who are going to have roles in healthcare delivery. All those people need to understand, how we steward the profession. And there's no better time than now, with the sort of confluence of events happening right before our eyes, for us to really take that on. So I appreciate you, centering us on that important aspect of the dialogue as well.
Yeah, it's, when we start talking about, we set this up to talk about this show, to talk about higher education, but so much flows from from higher education, from the admissions process, the readiness process, to how are people being trained when they're in the institutions? What happens when they leave the institutions? Is this creating, pipeline issues? How are clinics being, serviced? I mean, it's just so many things. Just Dr. Thornton, when you were talking before, something came up for me, just thinking about, how is this impacting just even scholarships, funding? Our students, is when you start talking about some of the socioeconomic challenges, is the money even available? Even if the readiness is there, they want to go to school, they've gotten past all the hurdles of the virtual versus in-person and hybrids and all of that. Is the money even present? Or are we going to see some of these challenges later on down the line as endowments start to suffer? And when you have students that are working in a virtual environment, sometimes when students go away to college, they escape an environment that is not a great learning environment. And so that's also another challenge when students are working from home. Are they working at home in an environment that is conducive to learning? And so, those are some of the things when I start thinking about higher education, thinking about certain populations, like, is this real? Is this something that people are really experiencing? And so I ask either one of you, have you, identified some of these challenges or see some of these challenges coming down the line?
I just was going to jump in as you were talking. It made me think, just about the sort of financial impact, and our sort of almost first thoughts and concerns as we begin to sort of see the pandemic sort of unravel, on higher education, our I'm just kind of really speaking in general terms here, but at my institution, certainly our hospital and our medical center became one of the major hubs in New York City for taking care of COVID patients. We largely, essentially, became a COVID hospital. All of the other sort of aspects to care were sort of ramped down, and the focus was on COVID. And there were a few other hospitals around the city that did the same thing. And but just speaking largely across the country, it's a lot of institutions had to shift their sort of focus given the times, and that created a pretty large financial hit. I know, certainly for a number of institutions, there have been cuts to staff. I think at many sort of academic medical centers, the sort of clinical enterprise helps to help the education, world in terms of, the financial support. But there's been, cuts as far as, programming and staff that have, trickled down to various departments. One of the things that we talked about, and I think, among my diversity colleagues in the diversity world, we were wondering, because of the impact of COVID-19, how would that now impact diversity efforts? For a number of years, we were moving. We had this sort of movement of ramping up programs and starting new initiatives and starting fellowships and getting grants, and now that the resources are shrinking and tightening, how is that now going to sort of impact our efforts, which oftentimes at the bottom line require resources? So I'm talking really from a sort of institutional side, but that's one of the things that we were concerned about, and I think we still to some extent share those concerns about how institutions will be able to support activities of inclusion and belonging and diversity, given the sort of strain on financial resources. And I'm happy to say that at my institution, we've been able to continue all the things that we're doing, if not grow in certain areas where we had planned to grow. We've had to think about things a little bit differently and get creative in some areas. But I know I'm at a very sort of resource-rich institution. But at a lot of institutions, they may not necessarily have that luxury. So, that's one of the things that had been on my mind as you brought up scholarships.
Yeah, I think both of you are with institutions that are probably in a different position than some of your smaller colleges that might not have as many resources, may not have the endowments that that you likely have. So you're in a little bit different position, but I think in the country we're also dealing with kind of these two major events happening at one time, and that's the COVID-19, but it's also an awareness around the disparities in the U.S., whether it's the health disparities that's been really outlined with the difference in how COVID is impacting some communities over other communities, whether it's the racial inequities that have been highlighted by some of the racism that has been captured on video. Not that the racism wasn't there before, but it's being captured for the world to see. So even though we're experiencing some of these financial downturns, in institutions and organizations probably ordinarily would say, hey, listen, we got to cut the diversity program. It's now this challenge of, is this a time to cut the diversity program when the world is looking at us saying, how are you handling these issues around diversity, equity, and inclusion? So it's a really interesting time that we're in.
I agree. And I would just say that in addition to that, even, sort of normal, quote unquote, steady state before this, we know that many students in higher education, were struggling to make ends meet before the pandemic, to do school and, feed themselves and their families. And I think many times those issues are, particularly hitting hard folks who are trying to work and better themselves professionally at the same time, whether that's in getting, a 2-year degree or a 4-year degree. And now more than ever, I think both the strains of the economic challenges compounded with the strains of, potentially things they relied on if they were, parents, students working, to have those additional, the support of like in-person school for your children. All of those things may be hitting, and this is not an area where I really have expertise at all, but maybe hitting those students even harder than in places where, particularly in graduate education, where people are, and in, we're talking about very rarefied here, academic medical centers, where it's a highly select, intense, resource intense environment where the training is full time. And like I mentioned, there are students who I know of who are also trying to hold down a job on the side while they're doing full-time programs to help supplement what family members have lost with job losses. But I think if you think about the totality of, students in higher education programs and what people are up against, particularly people who were already, really seeing, having to work and do school simultaneously to better themselves or to get access to that next opportunity, maybe particularly at risk or hard hit. And so I think there's a lot of questions, not to go completely off topic, but there's so much investment needed to help all segments of our economy and our future workforce really recover. I think about all of the young people who graduated high school on Zoom, or who graduated college on Zoom, and we're looking at a job market where potentially, the best opportunity in some places back in March or April might have been to get yourself, trained up in being a contact tracer or something. I mean, it just creates a lot of challenges for people making that progression, and for us ensuring that we have really developed the talent that we'll need, to continue to prosper, and even, hopefully in the future to, to prosper in new ways as a nation, and to recover from, all of the ways that people are being affected. We need to be investing in our youth right now, because we need them more than ever to be prepared, to enter the workforce. And I will say, I'm just constantly amazed at, from all ages, how quickly they adapt to using the technology and making sense out of these kind of remote platforms and get conversant in them and figure out ways to be creative with them, to use them to connect with one another. I believe in that human to human personal contact, but I think this is really one of those times where our youth, our young people in, college, graduate school, we really need to be figuring out ways to invest in them and to give them a pathway to know that they can, to support their success, because we need that talent, that pipeline of talent to continue. And it's just so critical. And it's one of those things that I think a lot about. I still try to set up Zoom coffee meetings with undergraduate freshmen who are, in their childhood bedroom trying to figure out how to be a college student. I mean, it's just really, really challenging for them. And so as faculty, I think that's something we take very seriously, trying to support them and understand what's going to help them succeed and get through this really difficult phase.
I tell you, in this both of your contributions to this profound conversation has been excellent. I've thought about 3, 4, maybe 5 profound conversations just from what you've been talking about, like, yeah, we can really do a deep dive into that. Yeah, that's a whole nother that's a whole nother segment. So it has been absolutely wonderful, the conversation. I do want to just pose one other question, because I've seen a question come through in terms of how do you foresee transformation happening in terms of the upcoming semesters as a result of kind of the lessons learned so far?
Yeah, thank you, Linda, for asking that. And I really appreciate Dr. Thornton, mentioning, this sort of aspect of, in some sense, we're in a new world now where, especially for parents or college students, trying to navigate, virtual workspaces, education, almost simultaneously. I have, 4 kids myself, and certainly when the pandemic hit, we were just having a very tough time with the virtual learning. I mean, I thought I was pretty good with computers, but it was a complete challenge. And I think we've tried to sort of come to some scramble to some sort of solution this academic year. My wife has largely taken on the brunt of homeschooling, but even that is still a huge sacrifice. But not everybody has that sort of privilege, and there are people who are working full time and also trying to manage the educational atmosphere of their students. So I think we need to really think about the challenges that face us, right? And not just us as individuals, but like our communities and the most vulnerable people in our communities. Like whether it's challenges around internet access at home, whether it's challenges around working and higher education. Maybe we need to be thinking about scholarships for college students who have children, so that they can get daycare, so that they can take the classes that they need to take. Maybe we need to be thinking about the sort of childcare services that we offer our employees, especially during this day and age. We need to be coming up with real solutions to some of these challenges that don't just affect the most privileged among us.
All right, I think we got about 2 minutes before we are at the top of the hour, and so I'd like to thank our profound conversationalists, Dr. Thornton and Dr. Lambert, for being with us today. The information you shared with us today was invaluable, and we look forward to having you back again. And I'll just, Kareem, I don't know if you want to say some closing words before we close out.
Yeah, I'd like to actually thank you. I'd like to just do some basic acknowledgments. MLPI is the executive producer of Profound Conversations. Media expression and production is done by Leah Network. Webinar technical and logistics are produced by Erica Christie and Khadija Ali. Graphics and animation are from Design Cafe. And today's host is the wonderful Linda Howard. Yours truly. And our guest today, Dr. Marcus Lambert from Cornell Weill University, and Dr. Rachel Thornton from Johns Hopkins. And next week, I will be looking at issues around HR 40, reparations, and reconciling the debt that America owes to former enslaved people of this land. Also want to bring mention to we have a YouTube channel, Profound Conversations, and we also have an after broadcast toolkit. If you're interested in receiving the links, the video, audio links, and plus more, subscribe on our website, and then you'll receive that every week after our broadcast. Thank you so much for a wonderful episode, doctors. And thank you, Linda.
Thank you.
Thank you very much.